The last time we met, we started our discussion on venous thromboembolic disorders. Uh, just a quick recap. We said VT is divided into DVT and P. And basically, when you say DVT, we are looking at the formation of clots within the deep veins. And we said usually DVT affects the lower extremities compared to the upper extremities. And depending on the location of the clot, DVT can be subdivided into proximal DVT and distal DVT. We mentioned some veins that are involved in the proximal DVT, the iliac, the femoral, and the popliteal. And for distal, we mentioned the peroneal, the anterior tibial, posterior tibial, and the muscular vein. So this was what we said about DVT. Then we proceeded to talk about the pathophysiology. Basically, we said it hinges on three main things. And these things come together to form what we call the virtuous triad. Basically, this triad is made up of endothelial injury, blastasis, and hypercoagulability. We explained all of them. Then we moved on to talk about some risk factors for DVT. We said that DVT, the risk factors for DVT are subdivided into three. So you have the weak risk factors, the moderate, and the high risk or strong risk factors. So we're able to subdivide the risk factors into these three categories. And we also mentioned that all these involve the formation of clot involves clotting factors. So we went through the clotting cascade. We said we have two main cascades, meaning the extrinsic and the intrinsic. But they both come together to form the common pathway. So that's the third pathway. And we said the intrinsic, all the clotting factors are within. It's usually an endothelial injury that will trigger the effect of this intrinsic clotting cascade. For extrinsic, you need an external force, usually trauma, and that will cause the release of tissue factor or thromboplastin. So that initiates the clotting cascade in the extrinsic pathway. And we said the purpose of all these pathways to form factor 10A. Once you form factor 10A, you've reached the common pathway. So that's what we discussed in terms of the clotting cascade. And we said it's very important to know the pathway because when it comes to the medications, we'll be looking at the target site for the various medications. Then we proceeded to talk about the clinical presentation of DVT. He said that clinically can present with swelling, that is the most specific sign of DVT. You could have differential warmth, you could have pain or tenderness, you could have superficial veins on the legs showing that there is a blockade. You could also have, for very severe cases, you could have cyanosis. And we mentioned one particular type of DVT, which is associated with cyanosis, phlegmasia ceruleus dolens. So we mentioned all these things. Then we proceeded to talk about the Wells score. We said when you suspect someone has DVT, one of the first things you do is the Wells score. So based on the Wells score, you decide whether it's DVT likely or DVT unlikely. Depending on whether it's DVT likely or DVT unlikely, that would influence your next step. So if it's DVT likely, then you want to confirm with a bedside ultrasound. So a Doppler ultrasound to see whether there's actually clots within the veins. If it's DVT unlikely, then you want to proceed to do D-dimers. And we said D-dimers has a high negative predictive value, but a low positive predictive value, meaning that if it's absent, if DVT is absent, D-dimers is very, very specific. But if it's present, it doesn't tell you there's DVT or is DVT, but it can be elevated in other conditions like pregnancy, cancer, infections, and all that. Then we also proceeded to talk about the other ways of diagnosing. So aside the war score, you can do the Homan's test, which is a bedside test, where you try to dorsiflex the affected limb. Whilst you are trying to do that, the patient will feel pain around the affected area. So that's a positive Homan's test. Then we also talked about the ultrasound and all that. I think that was the last thing we talked about, the diagnosis. And I said the next time we meet, we'll start with the management. So any questions from all that we've discussed so far concerning DVT and P before we proceed? Are there any questions or you're okay? Hello? Can you hear me?
Yes, please, we're okay.
Okay, all right. So let's proceed to talk about the management. So for the management of DVT, basically, before you talk about any management, you should know that the management is subdivided into two. So you have pharmacological and non-pharmacological. So pharmacological and non-pharmacological. So we talk about both of them. So usually for non-pharmacological ways, most of them are for preventive therapy. So when you look at most of our non-pharmacological ways, it's for prevention of DVT. But once you develop DVT, most of the management is skewed towards pharmacological, unless you have contraindications, and that would require that non-pharmacological therapies may be used when treating. Other than that, most non-pharmacological will be preventive, then pharmacological will be treatment. So what are some of the non-pharmacological ways of preventing DVT? Any ideas? Anyone? Non-pharmacological ways of preventing DVT. At the word, how do they prevent DVT? Non-pharmacologically.
Wearing compression stockings.
Okay. Wearing compression stockings. What's the difference between compression stockings and TED stockings? Are they the same? Compression stockings and TED stockings. I'm sure you've heard of TED stockings. What does the TED stand for? TED. TED. What does it stand for? Anyone?
It stands for thromboembolic deterrent.
Yeah, so thromboembolic deterrent. So looking at TED stockings and compression stockings, which one would you use to prevent DVT?
The third stockings.
Yeah, so the TED stockings. So from the name, thromboembolic deterrent, we are giving it to prevent thromboembolic conditions. So we use TED stockings in the prevention of DVT. What do you use compression stockings for? Any ideas what we use compression stockings for? I think we've discussed this already.
Treatment for varicose veins.
Exactly. So patients with venous disorders like varicose veins, chronic venous insufficiency, or you have lymphatic conditions like lymphedema. So these conditions, we use compression stockings. But for DVT prevention, use TED stockings. The other difference is that TED stockings are used for non-ambulatory patients. So patients who are immobile in bed. So the patients who are immobile in bed are at risk of developing DVT. Remember that bed rest for more than 3 days is a risk factor for developing DVT. So such patients are usually immobile. But compression stockings are used in ambulatory patients. So patients that are mobile. But at times it's not even the patients that were. Some nurses, you see some nurses wearing compression stockings. Because of the nature of the work, they tend to stand a lot. So they are at risk of developing these varicose veins and all that. So they tend to wear some compression stockings. So it's not just for the patients that have varicose veins, lymphedema. Ambulatory patients can wear compression stockings, but TED stockings are worn by non-ambulatory patients. And the last difference is the pressure gradient. The pressure differ. So when you are looking at TED stockings, you are looking at a pressure gradient of 8 to 18 millimeters mercury. So that's usually the pressure gradient for TED stockings. But compression stockings can range from 20 to 40 millimeters mercury. So you have differences in the type of condition that you can use. TED for DVT prevention, compression for chronic venous insufficiency, varicose veins, lymphedema. Then when it comes to the type of patient, you use TED stockings for non-ambulatory patients, then compression stockings for ambulatory patients. Then the pressure gradient, TED stockings 8 to 18 millimeters mercury, then compression stockings 20 to 40 millimeters mercury. So in our case here, we'll be using TED stockings. So that's what is recommended for prevention. Aside that, what other things can you use to prevent DVT? Non-pharmacologically. All right. So aside the TED stockings, we also have intermittent pneumatic compressions. So we have a device called intermittent pneumatic compression. Just that it's not readily available in our settings. So we tend not to see them a lot. So that one, just like the TED stockings, but this one comes with a machine that helps to regulate the pressure gradient. And the pressure is not continuous. That's why we call it intermittent. So it delivers pressure at a point in time. So that's intermittent pneumatic compression. It's in fact even more effective than the TED stockings. But in terms of availability, it's not readily available and it's expensive too. And the other thing that can also be done non-pharmacologically is IVC filters. So patients who have contraindications to pharmacological DVT prevention can be given IVC filters. So for instance, if the patient develops a hemorrhagic stroke, and you know for stroke, hemorrhagic stroke, the patient is likely to be immobile in bed for some time and will be at risk of developing DVT. For such patients, you can use TED stockings, you can use pneumatic compression as prevention. But the moment they develop a clot within the veins. What you want to prevent is you want to prevent the clot from being transferred from the deep veins to the pulmonary vessels. So the immediate risk you are trying to avoid is a DVT potentially being embolized to form a P. So what we can do is we can insert what we call an IVC filter. And IVC stands for inferior vena cava filter. So inferior vena cava filter. You know, you have two main vena cava. We have the superior vena cava and we have the inferior vena cava. So the superior vena cava drains blood from the upper extremities back to the heart, while the inferior vena cava drains blood from lower extremities back to the heart. So what we want to do is we want to prevent the clot from moving from the lower extremities to the heart and potentially getting to the lungs. So we insert a filter within the inferior vena cava, and all the blood that is being drained from the lower extremities will be trapped or would be filtered by the IVC filter. So that if there's any clot in there, that clot will be trapped by the filter and allow the blood to return back to the heart without causing PE. So that is also one of the interventions that can be done. Just that very expensive, not readily available. So we still tend to use our pharmacological therapies. If the patient has hemorrhagic stroke after 48 hours, you can still do the pharmacological, your Clexane prophylaxis. So that's what we use in our settings. Aside that, for treatment, non-pharmacological, if the patient has a clot within the lower extremities and there's contraindications to the pharmacological therapies, what can be done is you can do thrombectomy, where they try to remove the clot from the area of occlusion. So they can do surgery to remove. So you can either do thrombectomy or embolectomy. So if you are removing a thrombus, thrombectomy. If you are removing an emboli, embolectomy. So these are surgical interventions that can be done. So all these are non-pharmacological therapies. Just that most of them are not done in a setting. We rely more on the pharmacological therapies when it comes to DPT and PE. Any questions before we proceed? Do you have any questions? All right, let's move on. So we'll be looking at the pharmacological therapy. And the pharmacological therapies, remember the introductory session, we said the nature of clot that is formed in venous thromboembolic disorders is a red thrombus. And the red thrombus, we said, is fibrin rich, a lot of clotting factors. Pulse for arterial thrombosis is the white thrombus, which is platelet rich. So we tend to use antiplatelets. So because of the nature of the clots formed in venous thromboembolism, we'll be using more of anticoagulants because the clot is fibrin rich. So we use more anticoagulants. Aside anticoagulants, we can also try to break down the clot. So that is where fibrinolytics come in. So you can either use anticoagulants or fibrinolytics, but we don't use antiplatelets. Antiplatelets is reserved for arterial thrombosis, whilst anticoagulant is used in venous thrombosis. So what are some of the
Hello, Doc, please
classes of
can you take that question?
anticoagulants you know? Hello?
Hello, Doc, please can you take that question again? The line seems to
Yeah, so I was saying that the purpose of using anticoagulant in venous thromboembolism is because of the nature of clot that is formed. So we said that in the veins, blood moves very slowly, and because of that, there's blood spaces, you could have clot formation. And the type of clot that is formed is called red thrombus. And these red thrombus are fibrin rich. So because of that, we use anticoagulants. Whilst in the arteries, blood moves very fast and you have a lot of platelets. So the platelets can adhere to the endothelial wall, aggregate, forming clot. The type of clot formed within the arteries are known as white thrombus because they are platelet rich. Because of that, we use antiplatelets for arterial thrombosis. Then we use anticoagulants for venous thrombosis. All right. So I was asking the various classes of anticoagulants, Can anyone tell us some? Any class of anticoagulants, Anyone?
Please, the direct acting oral anticoagulants.
Yeah, so the direct acting oral anticoagulants, the DUACs. So the DUACs. All right. So for the DUACs, we have subclasses. So we have the factor 10A inhibitors, and we have the direct thrombin inhibitors. So direct thrombin inhibitors, then factor 10A inhibitors. Any other classes of anticoagulants,
Please, we also have low molecular weight heparins.
Yeah, so the heparins. For the heparins, subdivided into two. We have the unfractionated heparins, and we have the low molecular weight heparins. So unfractionated heparin and low molecular weight heparin. Any other? Any other? What class of anticoagulant is warfarin?
Vitamin K
Vitamin K
vitamin
antagonist.
Yeah, so vitamin K antagonist. All right. So what I need you to know is that we have a lot of classes of anticoagulants. We take them one after the other and we talk about them. So for the heparins, we have unfractionated heparin and low molecular weight heparins. Then we have the coumarins. For the coumarins, we have the vitamin K antagonists like warfarin, and we have um, dicumarol. So we have dicumarol, we have acicocoumarol, and all that. Then we have the indane diones are also subclasses of the coumarins. So these are usually not common. Mm. So the indane dione derivatives and we have the coumarins, the vitamin K antagonist like warfarin. Then we also have the factor 10A inhibitors. So factor 10A inhibitors, you know the common ones, the rivaroxaban, apixaban, edoxaban. Then we also have the direct thrombin inhibitors. Under the direct thrombin inhibitors, we have the bivalent ones and the divalent ones. So for direct thrombin inhibitors, it's subdivided into the bivalent and the monovalent. So for the monovalent or the univalent, usually the agatroban, dabigatran, these are the univalent ones. Then the bivalent ones is the hirudins. So you can have bevalirudin, you can have hirudin and all that. Then when it comes to I think I've mentioned the factor 10 inhibitors. So these are the classes. So we take them one after the other and we talk extensively about them. Any questions? All right, so let's start with the coumarins. For all the classes, we will talk about the common ones. So for the coumarins, even though you have warfarin, we have dicumarol, we have the indane and all that. But we'll talk about warfarin because that's what's available and that's the most common one. We'll talk about warfarin. Okay. So what do you know about warfarin? In terms of the mechanism of action, how does it act? Who can tell us? All right. So the first thing I want you to know about warfarin. Okay, someone talking.
I wanted to give my contribution. That
Okay,
so
you can go ahead.
warfarin is a vitamin K antagonist in that it inhibits vitamin K epoxide reductase, and vitamin K is needed by certain clotting factors to as a cofactor for clotting to occur. So through the inhibition of that enzyme, that form of vitamin K is not readily available to these clotting factors for the clotting to occur. That's a little I know.
Okay, so that's very good. All right. So the first thing I want you to know about warfarin is that warfarin is a racemic mixture. So warfarin is a racemic mixture. So remember back in school when you were talking about stereochemistry, we were talking about agents that act as racemic mixture. When you talk about racemic mixture, you are looking at a mixture of two mirror images. So we have these mirror images, and these mirror images are what we call the enantiomers or the enantiomers. And these enantiomers, we have the R component and we have the S component. So what I need you to know is warfarin is a racemic mixture. And by saying it's a racemic mixture, it means that it has an equal component of two enantiomers that are mirror images of each other. Yes, that usually for racemic mixture is only one component which is active. The other component is inactive or usually less active. When you look at warfarin is made up of R warfarin and S warfarin. So there's R warfarin and there's also S warfarin. S warfarin is the active component of warfarin. It's about 3 to 5 times more potent than R warfarin. So I'm saying warfarin is a racemic mixture made up of R component and S component. And the S warfarin is the active component. It's about 3 to 5 times more potent than R warfarin. So that's like other medications that you know, like omeprazole, esomeprazole. Omeprazole is a racemic mixture. So there's R and S components. But the S component is the active, which is the esomeprazole or the Nexium that you have available. So that's how warfarin behaves. The other thing is for the mechanism of action, as you rightly said, warfarin is a vitamin K antagonist. And by inhibiting vitamin K, it prevents the activation of vitamin K dependent clotting factors like 2, 7, 9, and 10. So that's, in simple terms, the mechanism of action of warfarin. But we will be going in depth. So we'll go to the molecular basis. If you are saying it's vitamin K antagonist, how is it exerting this effect? So that's what we really want to understand. So who can tell me, how does vitamin K exist? So in which form does vitamin K exist? The naturally occurring form of vitamin K. In which form does it exist? Can anyone tell me? Okay. So what I need you to know is vitamin K exists in inactive forms and the active form. The naturally occurring forms of vitamin K are usually inactive. So they have to be activated. The naturally occurring form of vitamin K is vitamin K quinone. So vitamin K quinone, that is the naturally occurring form of vitamin K. And we also have vitamin K epoxide. Vitamin K epoxide is also inactive and is obtained from the recycling process of vitamin K. In the recycling process of vitamin K is inactivated to vitamin K epoxide. So take note of that. So the naturally occurring form of vitamin K is vitamin K quinone, which is inactive. And we also have vitamin K epoxide, which is obtained from the recycling process of vitamin K. And that is also inactive. So take note of these things. Vitamin K quinone and vitamin K epoxide. These are inactive forms of vitamin K. So what happens is that these inactive forms have to be activated. So they have to be converted to the active form. And this conversion is done by an enzyme called vitamin K epoxide reductase. So vitamin K epoxide reductase. So this vitamin K epoxide reductase converts the inactive forms of vitamin K, which is vitamin K quinone or vitamin K epoxide, to the active form of vitamin K. So looking at the reaction that is taking place. So if you are saying the inactive form is vitamin K quinone, and you have an enzyme called vitamin K epoxide reductase acting on vitamin K quinone to convert it to the active form, what do you think the active form of vitamin K would be? Looking at the enzyme acting on vitamin K quinone. Who can tell
So
me?
can you repeat that again? Please, the line was breaking. The enzyme part.
What I'm saying is the inactive form of vitamin K is vitamin K quinone, and we have vitamin K epoxide. These are inactive forms of vitamin K. The naturally occurring form is vitamin K quinone, and the one that is obtained from the recycling process of vitamin K is vitamin K epoxide. So what happens is these two are inactive, so they have to be converted to the active form. And this conversion is done by an enzyme called vitamin K epoxide reductase. So vitamin K epoxide reductase would convert the inactive forms of vitamin K to the active form. So I was asking you, looking at the name of this enzyme, if it's converting vitamin K quinone, which is inactive, to an active form, what do you think the active form of vitamin K would be?
It will
So it will
be
be
vitamin K
vitamin K
hydroquinone.
hydroquinone. Yeah. So it's a reduction process. So what is happening is an oxidative reductive process. And you remember from SHS that in reduction is addition of what? Hydrogen. So addition of hydrogen to vitamin K quinone will convert it to vitamin K hydroquinone. So vitamin K hydroquinone is the active form of vitamin K. The active form of vitamin K is vitamin K hydroquinone. So take note of that. Are we clear on that?
Sir, please, can you kindly take it again?
I was saying that we are having a reduction reaction, and this reduction is supposed to convert inactive vitamin K to active vitamin K. The inactive forms are vitamin K quinone and vitamin K epoxide. Mm? It's acted on by the enzyme vitamin K epoxide reductase. And this enzyme converts the inactive form of vitamin K to active form of vitamin K. And the active form of vitamin K we are saying is vitamin K hydroquinone, or the active form is called vitamin K hydroquinone. So that's what we need to establish before we move on.
Yes, please, thank you.
Okay. So what happens is that this active form of vitamin K, it is what is going to serve as a cofactor for a certain enzyme that is responsible for activation of certain clotting factors. So we always say that there are some vitamin K dependent clotting factors. And these vitamin K dependent clotting factors, we know we have factor 2, factor 7, factor 9, and factor 10. These are vitamin K dependent clotting factors. So what this means is that these clotting factors require vitamin K for their activation. So that is why we call them vitamin K dependent clotting factors 2, 7, 9, and 10. So what happens is that the active form of vitamin K that we have formed is going to serve as a cofactor for a certain enzyme. And this enzyme would be the enzyme responsible for activation of the factor 2, 7, 9, and 10. So I'm taking it again. So that vitamin K we are forming, the active vitamin K, is not going to do the activation directly, but rather act as a cofactor for a certain enzyme. And this enzyme is called the gamma glutamal carboxylase enzyme. So the gamma glutamal carboxylase enzyme. This enzyme is responsible for the activation of the factor 2, 7, 9, and 10. And before this enzyme can activate these clotting factors, it requires vitamin K in its active form, which is hydroquinone. So if you have vitamin K, which is active, it will serve as a cofactor for gamma glutamal carboxylase enzyme. And this enzyme will cause the activation of factors 2, 7, 9, and 10. So what happens is that, remember in the clotting cascade, I told you when I say factor 2 means it's inactive. But when I say factor 2A, the A there means activated factor 2. So the activation we are talking about is conversion of factor 2 to 2A, 7 to 7A, 9 to 9A, and 10 to 10A. This activation process is done by the gamma glutamal carboxylase enzyme. That process I just talked about, 2 to 2A, 7 to 7A, 9 to 9A, and 10 to 10A. That process is called carboxylation reaction. So it's a carboxylation reaction. And it's done by the gamma glutamal carboxylase enzyme. And this enzyme requires active vitamin K to serve as a cofactor. So when you give warfarin, what warfarin does is warfarin inhibits vitamin K epoxide reductase. So that enzyme that is responsible for converting inactive vitamin K to active vitamin K. That enzyme is called vitamin K epoxide reductase. So when you give warfarin, warfarin inhibits vitamin K epoxide reductase enzyme. By doing that, it prevents the conversion of inactive vitamin K to active vitamin K. Once you prevent that conversion, what happens is you wouldn't have active vitamin K to serve as a cofactor for gamma glutamal carboxylase enzyme. Therefore, the carboxylation reaction, which is factor 2 to 2A, 7 to 7A, 9 to 9A, and 10 to 10A, wouldn't happen. So if you are preventing the activation of clotting factors, in essence, what you are doing is you are preventing clot formation. So that is the molecular mechanism behind warfarin activity. I'm taking it again. I said vitamin K exists in the active form and the inactive form. And I said the inactive form, the naturally occurring form is vitamin K quinone.
And the one that is obtained from the recycling process of vitamin K is vitamin K epoxide. What happens is this enzyme, vitamin K epoxide reductase, converts the inactive vitamin K to the active form. And the active form of vitamin K is called vitamin K hydroquinone. This vitamin K hydroquinone serves as a cofactor for an enzyme called gamma glutamyl carboxylase enzyme. This gamma glutamyl carboxylase enzyme is going to convert or is going to cause the activation of factor 2 to 2A, 7 to 7A, 9 to 9A, 10 to 10A. And this process is called the carboxylation reaction. It requires gamma glutamyl carboxylase and requires vitamin K in the active form to serve as a cofactor for the enzyme. So when we give warfarin, warfarin inhibits vitamin K epoxide reductase. By doing that, it's preventing the formation of the active vitamin K, which is needed as a cofactor for the gamma glutamyl carboxylase enzyme. So in a nutshell, we are explaining how warfarin is able to inhibit the activation of vitamin K dependent clotting factors. Are you okay? Any questions or is clear? Hello? Please, it's clear.
Okay. So if it's clear, let's move on. So the next thing I want to talk about is why do we combine warfarin and clexane? So when you want to start, so we just talked about the mechanism of action and all that. So looking at this, factor 2, 7, 9, and 10, which pathway do you think warfarin will be acting? We went through the clotting cascade, so the intrinsic, the extrinsic, the common pathway. So looking at factor 2, 7, 9, and 10, which pathway do you think warfarin will be acting?
The intrinsic pathway.
The intrinsic pathway. Okay. Why the intrinsic pathway?
Because that is where these clotting factors are. Factor 7.
Why do you find? Okay. Factor 7. Factor 7, are you sure it's in the intrinsic pathway?
Sorry. Factor 9.
So factor 9 is in the intrinsic. What about factor 7?
Factor 7 is in the extrinsic pathway.
Yeah,
So
factor
factors
7 is in the
7
intrinsic.
and 9.
So what about factor 2 and factor 10?
Common
Factor
pathway.
2 and 10 are in the common pathway.
So looking
Factor,
at the effect of warfarin, warfarin majorly targets the extrinsic pathway and the common pathway. So when you look at the extrinsic pathway, it starts with trauma causing the release of tissue factor, and that will cause cause activation of factor 7 to 7A, then 10 to 10A. All the clotting factors that are involved in the extrinsic pathway are inhibited by warfarin. Then when you look at the common pathway, there's factor 2 to 2A. That is also inhibited by warfarin. And you have factor 10 in there. The only exception is factor 9, which is in the extrinsic pathway. And when you look at the intrinsic pathway, when you look at the intrinsic, there are lots of clotting factors in the intrinsic pathway. So just factor 9 is not enough. So just factor 9 is not enough. Now, when you look at the extrinsic pathway, the moment you inhibit factor 7 and factor 10, the extrinsic pathway has been inhibited. So that is what you should take note of. Warfarin majorly acts in the extrinsic and common pathway. So because of that, we usually use the INR as a monitoring parameter, because the INR, what the INR stands for is International Normalized Ratio. And it's basically a ratio of prothrombin time of the patient divided by prothrombin time of the standard or control. It's a ratio. So the purpose of using the INR is the INR sort of targets the extrinsic pathway and the common pathway. So it's able to be used to monitor the activity of warfarin, because warfarin majorly acts in the extrinsic and the common pathway. Then when you look at the heparins, we'll talk about the heparins later, but the heparins tend to act in the intrinsic and the common pathway. So take note of that. What I wanted us to talk about is why we combine warfarin and clexane. You can tell me the reason why you combine warfarin and clexane. So when we want to start warfarin in someone who has DVT, you don't just start warfarin straight away. You combine it with clexane. So what's the rationale behind that?
So please, it takes warfarin about 5 days to get to its therapeutic level, or for it to elicit its therapeutic effects.
Okay. So what you are saying is the onset of anticoagulation of warfarin is delayed. So in terms of the onset, it will take about 48 to 72 hours for the onset to kick in. And the full anticoagulation effect, or the full therapeutic anticoagulation, is realized after 5 days. So the next question is, why does warfarin have a delayed onset of anticoagulation? Why is the onset of anticoagulation delayed? Anyone?
The onset of action of warfarin depends on the elimination of the various clotting factors. So the clotting factors that are activated have half-lives. So depending on the half-life of the particular clotting factors, how should I put this? But yes, the various clotting factors have half-lives. So the time taken for them to be cleared would delay the onset of action of warfarin.
All right, that's very true. So what I need you to understand is warfarin doesn't have effect on already activated clotting factors. So the already activated clotting factors, warfarin doesn't have any effect on them. The effect of warfarin is on the new clotting factors. So the new ones that are yet to be activated, that is where we see the effect of warfarin. But the already activated ones, warfarin doesn't have any effect on them. So let's establish this fact. Let's go back to the mechanism of action. So if you remember, we said vitamin K, the active vitamin K, will serve as a cofactor for the enzyme gamma glutamyl carboxylase. And this converts factor 2 to 2A, 7 to 7A, 9 to 9A, 10 to 10A. Before or when you give warfarin, warfarin inhibits the vitamin K epoxide reductase. And once it inhibits that enzyme, it prevents the vitamin K from being activated. And this vitamin K is only serving as a cofactor for the enzyme responsible for the carboxylation reaction. So if the enzyme has already been carboxylated or activated, warfarin doesn't have any effect because its effect is preventing the activation of clotting factors. So 2 to 2A, 7 to 7A, 9 to 9A, 10 to 10A, that's what warfarin is trying to prevent. But if 7A has been formed already, 2A, 9A, and 10A have been formed already, warfarin doesn't have any effect on them. So what happens is, before you start realizing the onset of anticoagulation of warfarin, these already activated clotting factors need to be eliminated from the body, as you rightly said. And all of them have half-lives, elimination half-lives. So depending on the elimination half-life of the various clotting factors, it will cause the onset of anticoagulation of warfarin to be delayed. So the one with the fastest elimination half-life is factor 7. So the half-life is 6 hours. Then factor 9, 24 hours. Factor 10, 36 hours. And factor 2, 50 hours. So you have factor 7, 6 hours. Factor 9, 24 hours. Factor 10, 36 hours. Then factor 2, 50 hours. So these activated clotting factors will need to be eliminated. So when you look at the one with the longest half-life, which is about 50 hours, it's usually an average. So the values I've given you is usually average, but it's a range. So looking at the half-life, 50 hours, that means it will take about 48 to 72 hours for you to start seeing the effects of warfarin, because the last one has a half-life of about 50 hours. So it's around that time that the onset will start kicking in. Other than that, all these would have to be eliminated before we start seeing the effects of warfarin. Is it clear?
Yes, please.
All right. So we combine clexane and warfarin because clexane has a faster onset of action and it has activity against already activated clotting factors. So the clexane has effect on already activated clotting factors. So we tend to combine clexane and warfarin so that clexane will start working before we start seeing the effect of warfarin. All right, so that's just one reason why we combine clexane and warfarin. Any other reason? Any other reasons? All right. The other reason is warfarin is prothrombotic. Warfarin is prothrombotic. So when we say something is prothrombotic, that means it has a tendency to cause thrombosis or clot formation. And isn't this very confusing? Because you just said warfarin is an anticoagulant, so it prevents clot formation. And another time, you are also saying warfarin is prothrombotic, meaning that it can potentially cause thrombosis. So why is that so? Can anyone explain why warfarin is prothrombotic? Anyone?
Initially, we spoke about natural anticoagulants being protein C and S, but warfarin can inhibit these natural anticoagulants, so it should have some prothrombotic activity.
Exactly so. So when I was talking about the virtuous triad, I talked about hypercoagulability and that we have body's natural anticoagulant, protein C, protein S. So what happens is these protein C and S, which are body's natural anticoagulants, are supposed to keep the clotting factors or the prothrombotic factors in check. These natural anticoagulant protein C and S also require vitamin K for the activation. So the activation of protein C and S is also dependent on vitamin K, just like we have vitamin K dependent clotting factors. The natural anticoagulants are also dependent on vitamin K. So when you give warfarin, what happens is warfarin inhibits the activation of vitamin K. For that reason, you don't have activated vitamin K to help also activate protein C and protein S. So if protein C and protein S are not activated, what happens is your prothrombotic factors take over because these protein C and S, which are natural anticoagulants, are supposed to keep the clotting factors in check. But you're giving warfarin, and warfarin has inhibited vitamin K, so you don't have protein C and S to be activated. So the already activated clotting factors that are still circulating in the system can potentially cause thrombosis. So within the first few days of giving warfarin is said to be prothrombotic, so it can cause clot formation. For that reason, we combine it with clexane so that clexane will sort of give a cover within the first few days to prevent clot formation whilst we await the onset of anticoagulation of warfarin. So warfarin would have a delayed onset, but within that time is delaying, it can cause thrombosis. So we combine it with clexane so that clexane will provide a cover so to prevent thrombosis from happening within the first few days before we start seeing the effect of warfarin. Is it clear?
No, sir. Please take it again. The protein C and
So
protein
I
S
said
part.
protein C and protein S also require vitamin K for their activation. And these are body's natural anticoagulants. They are supposed to prevent clot formation or thrombosis. So what happens is when you give warfarin, vitamin K is inhibited. So if you are not forming vitamin K, the active form of vitamin K, which is needed for protein C and S activation as well. What will happen is you don't have natural anticoagulants to keep the clotting factors in check. And these clotting factors, whilst they are still available and they are activated, they can always cause thrombosis. Mind you, warfarin that you give doesn't have effect on the already activated clotting factors. So these will still be there lingering in the system until they are eliminated by their various half-lives. So while they are there, they can cause thrombosis because the natural anticoagulant, which is supposed to keep them in check, is also inactivated because you don't have vitamin K for the activation. So we combine it with clexane because clexane would act within the first few days to prevent any thrombosis because it can act on the already activated clotting factors. So it can provide a cover within the first few days while we are awaiting the onset of anticoagulation of warfarin because it's delayed. It will take about 48 to 72 hours for you to start seeing the effect, and it takes about 5 days for the full effect to kick in. During all these time, the prothrombotic effects of warfarin can occur. So you want to give clexane in addition to the warfarin to provide a cover within these few days.
Thank you.
Okay. Any other questions? All right. So these are the reasons why we combine clexane and warfarin. We've mentioned three reasons. One is the onset of anticoagulation of warfarin is delayed. So you want to give something that has a faster onset. So you give it with clexane because clexane has a faster onset of anticoagulation. And we said warfarin does not have effect on already activated clotting factors. So you combine it with clexane to cater for the already activated clotting factors. And the last reason is warfarin is prothrombotic. So within the first few days, whilst we are waiting the onset to kick in, because protein C and S has also been inactivated, the patient can develop thrombosis. So we combine it with clexane to provide a cover within the first few days whilst awaiting the onset to kick in. Okay. So these are the reasons why we combine clexane and warfarin. So how do you monitor the effect of warfarin? We mentioned the INR is used in monitoring, but what's the INR target for your patient? If you put a patient on warfarin, what's your INR target? Anyone? Anyone to tell us the INR target when you put a patient on warfarin? Okay, so you should know what the normal INR is, and you should know the INR target when you put a patient on warfarin. So the normal INR is between 0.8 to 1.1 or times 1.2. It's between 0.8 to 1.1. Once you put the patient on warfarin, the INR target should be between 2 to 3. So between 2 to 3, warfarin has a narrow therapeutic index. So between 2 to 3, it's very narrow. If it's going beyond 3, that means the patient is at risk of bleeding. And when it's below 2, that means the drug is not within the therapeutic range to provide protection against thrombosis. So because of that, we try to keep this narrow therapeutic index of 2 to 3. So that's your INR target. So usually when you combine it with Clexane, before you even start, you may want to take a baseline INR to know where the INR was before starting the patient on warfarin and Clexane. Then after 3 days, you check the INR again. So on the third day, if it's between 2 to 3, you have to maintain the same dose of the warfarin for about 2 extra days to see whether it's still within the target. If after 5 days it's within the 2 to 3 targets, you can stop the Clexane and continue with warfarin alone. So the overlap is usually done to get INR target between 2 to 3. Once you get INR target between 2 to 3, you can stop your Clexane and continue with the warfarin. Okay, so let me ask you, why do you recommend that patients taking warfarin should take it at night? What's the rationale for telling them take warfarin at night? One. So the main reason for taking warfarin at night is because it allows you to adjust the INR, to adjust the dose based on the INR that has been checked for the day. So what this means is that when you tell the patient to take it at night, the following morning when they are coming to check their INR, they check their INR and it's say INR of 5. INR of 5 has exceeded the target, which is 2 to 3. So based on the morning INR of 5, you can decide to tell the patient reduce the dose from say 10 milligram to 5 for that particular day. So based on the morning INR, it allows you to adjust the dose of warfarin for that particular day. So that's the main reason for taking warfarin at night. The other reasons is the synthetic function of the liver is high at night. So where the clotting factors is highly produced is in the evening. So you want to tell them to take it at night. But the main reason is because you want to adjust the INR based on the morning. You want to adjust the dose based on the morning INR. Are we okay on that? Can we continue?
Doc, please, I have a question.
Sure.
Mm. Doc, so patients on warfarin, are you supposed to check the INR every morning as at when they are on it? Or we have specific time interval for the checking?
Yeah, so there are specific time intervals for the checking. So when you are initiating, you start by having a baseline INR. Then you put the patient on warfarin and Clexane. Then on the third day of putting the patient on warfarin and Clexane, you recheck again. If it's between 2 to 3, You have to continue for 2 extra days. Then on the fifth day, you recheck again. If it's between the 2 and 3, you stop your cleansing and continue the warfarin. Once you are continuing the warfarin, you have to, even though you've gotten your 2 to 3 INR target, but you still have to monitor to be sure that it's within that target. So after the 5 days, you first do every month, then with time you do every 3 months, every 6 months, then later it becomes yearly. So for the first few days, you want to make sure it's within the target. But after that, you can do it every month, every 3 months, 6 months, and becomes yearly once you are within the therapeutic range. So the purpose is to get the dose that would allow you to stay within the therapeutic range. If you've not gotten the dose that will allow you to stay within the therapeutic range, you will keep adjusting the dose till you get to the INR target of 2 to 3. Once we get that and it's maintained, you can even check the INR every 3 to 6 months yearly. Is it clear?
Yes, please. It's very clear.
Okay. Any other questions? All right. Let's talk about some few side effects um, of warfarin. So for warfarin, bleeding is one of the major risk factors that you can have from warfarin. So if you have a patient on warfarin who is bleeding, how would you mediate this adverse effect? So is there any antidote you can give when you have warfarin-induced bleeding? So maybe you stopped the warfarin, but the patient continues to bleed. Is there any antidote you can give? What antidote can you give?
Please, vitamin K.
Yeah, so vitamin K. We know it's vitamin K antagonist. So if you have warfarin-induced bleeding, you want to give vitamin K, and vitamin K will counter the effect of warfarin. So vitamin K can be given. All right. Then the other thing I also want to talk about is osteoporosis. So one of the side effects of long-term use of warfarin is osteoporosis. And can anyone tell me how warfarin causes osteoporosis? How does warfarin cause osteoporosis? So from the same mechanism, we said warfarin is vitamin K antagonist, so it prevents the formation of active vitamin K. This same active vitamin K is needed by a protein called osteocalcin. So there's this protein called osteocalcin, and this osteocalcin is involved in bone mineralization. So in the mineralization of bone, this protein osteocalcin binds to calcium, and once it binds to calcium, it's able to mineralize the bones, making the bones strong. So what happens is you are seeing this osteocalcin requires for gamma glutamyl carboxylase enzyme. This gamma glutamyl carboxylase enzyme is also responsible for the activation of osteocalcin. So once osteocalcin has been carboxylated or activated by gamma glutamate carboxylase. Osteocalcin can now bind to calcium to cause bone mineralization. But if you give warfarin, warfarin inhibits vitamin K activation. So you don't have active vitamin K to serve as a cofactor for gamma glutamate carboxylase enzyme. For that reason, osteocalcin is not carboxylated to the active form. So it's unable to bind to calcium. Once it doesn't bind to calcium, you have less calcium getting into the bones. Long-term use of warfarin can potentially lead to osteoporosis because osteocalcin is not being activated to cause bone mineralization. So the patient can develop osteoporosis. Is that clear? All right. Any questions on warfarin? Any questions on warfarin before we move on? All right. So let's move on to talk about the heparins. So for the heparins, I told you it's subdivided into two. We have the unfractionated heparins and we have the low molecular weight heparins. So looking at the name, one is low molecular weight, the other is unfractionated. The unfractionated heparin usually has a high molecular weight.
Please, I have a question on
So the high
warfarin.
molecular weight. Ah,
Dr. Shark. Yeah, please. I was wondering if you would tackle counseling points for warfarin or something like that.
yeah. So what do you think some of the counseling points will be if you put a patient on warfarin? What do you think some of the counseling points will be? You've mentioned one of them. One of them is to take warfarin at night because you want to monitor the INR the following day. So by giving the warfarin at night, it allows you to adjust the dose based on the early morning's INR target. Aside that, what do you think is necessary to tell the patient? So in terms of diet, how would
Okay,
you
so in
advise the
terms of
patient?
that, we advise the patient not to eat a lot of greeny food to avoid.
Okay. So you tell the patient to avoid green leafy vegetables. Is that what all of you tell the patient?
Please, you can also tell them that when they are brushing their teeth and they notice that they are bleeding, even with minimal exertion, they should report to the hospital.
Okay, so that's true. So you know it has a narrow therapeutic index. So when minimal exertion is causing bleeding, you want to be sure whether the warfarin is not beyond the INR target. So it's best they report so that the INR is checked to be sure it's within the target range. I was asking about the green leafy vegetables. Do you tell the patients to avoid green leafy vegetables because they are taking warfarin?
Doc, I learned that with the green leafy vegetables, either they stop taking it or they continue to take a constant amount of the green leaves that they've been taking every day.
Well, exactly so. So instead of telling them to avoid, it's best to tell them to maintain a constant intake of the green leafy vegetables they take. These green leafy vegetables contain vitamin K, and vitamin K counters the effect of warfarin. So you want to tell them that if maybe, so you make it practical. If you tell the patient maintain constant intake of green leafy vegetable, they may not understand in practicality. So if maybe they are the type they eat ampesi every day with contumely, we want to tell them maybe take one ladle of contumely every day. So that one ladle becomes a constant intake of green leafy vegetables they take on daily basis. And the purpose is that you want them to maintain that so that you are able to maintain them on a particular dose of the warfarin that would help them stay within the target 2 to 3. So if you tell them to avoid, maybe they take 2, 3 days, they are avoiding, realize that it will change the INR range. So you want them to maintain a constant intake so that if you put the patient on 5 milligram, 10 milligram, we know that if they take one ladle of contumely every day and you put them on 5 milligram, you still achieve the 2 to 3 target. But if they avoid totally, then it will affect the INR. So that is the advice you give them: maintain constant intake of the green leafy vegetable. Okay, so let's talk about the heparins. So for the heparins, I was saying we have low molecular weight heparins and we have the unfractionated heparin. So the low molecular weight heparin is what you know, the very common ones: enoxaparin, dalteparin, tinzaparin. So these are low molecular weight heparin: enoxaparin, dalteparin, tinzaparin. Then you have the unfractionated heparins. So in terms of molecular weight, the unfractionated heparin have a higher molecular weight compared to the enoxaparin, dalteparin. These are low molecular weight heparin. So when you look at the molecular weight of the unfractionated heparin, it's about 15,000 Daltons. So the molecular weight is 15, the average molecular weight is 15,000 Daltons. So the molecular weights are measured in Daltons. So 15,000 Daltons. Whilst the low molecular weight heparins usually have a molecular weight ranging between 4,000 to 5,000 Daltons. So 4,000 to 5,000 Daltons. So when you compare, you realize that unfractionated heparins have a relatively higher molecular weight compared to the low molecular weight heparins. The other thing I also want you to know is that these heparins are made up of polysaccharides. They're actually polysaccharides. And these are made up of various saccharide units. So you have a lot of saccharide units that come together to form a polysaccharide. So when you look at unfractionated heparin, it's made up of about 45 polysaccharide or saccharide units. So you have about 45 saccharide units. Whilst when you look at the low molecular weight heparins, they are made up of about 15 saccharide units. So you have 15 saccharide units in the low molecular weight heparins, then 45 saccharide units in the unfractionated heparins. This is very important when you get to the mechanism of action. So I'm just mentioning that these are made up of saccharide units, unfractionated 45 saccharide units, and the molecular weight is 15,000 Daltons, while low molecular weight is made up of 15 saccharide units, and the average weight is 4,000 to 5,000 Daltons. All right, what's the difference between these two? The unfractionated heparins and the low molecular weight heparin. What's the difference? Anyone? So we've talked about difference in terms of the weight, in terms of the saccharide units. What other difference can we have?
I think in terms of their bioavailability, I think the low molecular weight heparin have like a higher bioavailability, and then the unfractionated one has a lower bio.
Exactly so. So in terms of bioavailability, higher bioavailability for the unfractionated heparins, for the low molecular weight heparins compared to the unfractionated heparin. So that's true. Any other? So any difference in terms of monitoring? Which of them requires routine monitoring?
The unfractionated heparin.
Exactly so. So unfractionated heparin, once you put the patient on it, just like warfarin, you need to be monitoring. So unfractionated heparin, you need to monitor the activated partial thromboplastin time, which is the APTT, activated partial thromboplastin time. But with low molecular weight heparins like Clexane, there is no need to monitor. So they usually have a predictable pharmacokinetics. So there is no need to monitor. In extreme cases where we are dealing with very obese patients, um, then pregnant women, you may request for anti-factor 10A activity. Even that one is not readily done in the labs, so it's not routinely recommended. But what I need you to know is unfractionated heparin requires routine monitoring of APTT. Low molecular weight heparin do not require routine monitoring. Then what again? In terms of half-life, which one has a short half-life?
Unfractionated heparins have a shorter half life.
So that's true. The unfractionated heparins have a short half-life. So when you even look at the prophylactic dose of heparin, unfractionated heparin, you would have to do subcutaneous heparin 5,000 units every 8 to 12 hours. So you're either doing TDS or BD for unfractionated heparin. But Clexane prophylaxis for DVT is 40 milligram daily. So just once daily dosing is enough to prevent DVT because of the long half-life of the enoxaparin or low molecular weight heparin. But with unfractionated, you would have to do TDS or BD. Now, when you look at the metabolism, so heparin is metabolized by the reticuloendothelial system and also the liver. So you know the reticuloendothelial system where you have the spleen and you have the macrophages. So these help to metabolize unfractionated heparin and to some extent the liver. But for low molecular weight heparin, they are majorly metabolized by the liver and excreted by the kidneys. So in terms of renal impairment, for patients who have severe renal impairment, creatinine clearance less than 30, you would have to adjust the dose of low molecular weight heparin. But with unfractionated heparin, it doesn't require any dose adjustment in patients with renal impairment. So very little is excreted renally. So in terms of dose adjustment, unfractionated heparin, you don't need any dose adjustment. But with low molecular weight heparin, once the creatinine clearance is less than 30 ml per minute, you'd have to renally adjust the dose. And in terms of the antidote, once you have overdose and bleeding, protamine sulfate is able to completely reverse unfractionated heparin. So it's able to completely reverse unfractionated, but it's only partially able to reverse the low molecular weight heparin. So in terms of antidote reversibility, you have complete reversal for unfractionated heparin, but partial reversal for low molecular weight heparin. So these are some of the differences between unfractionated and the low molecular weight heparin. Are you okay?
Hello, sir. Please, you said that with renal impairment for the low molecular weight heparins, you said something below 30. I didn't hear that part, please. Can you please take it again?
Yeah, so I said renal impairment. If you have creatinine clearance less than 30 ml per minute, we would have to adjust the dose for Clexane. So you'd have to adjust the dose for Clexane if it's less than 30 ml per minute. So instead of doing DVT prophylaxis 40 milligram daily, you'd have to reduce the dose to 30 milligram daily once the creatinine clearance is less than 30. But for unfractionated heparin, I said you do not require any dose adjustment. Even in severe renal impairment, you don't adjust the dose. So you give the same dose. But unfractionated low molecular weight heparins like Clexane, you would have to reduce the dose.
Thank you.
Any other? All right, let's talk about the mechanism of action of the heparins. How do they act?
Hello, sir. If I have a question, um,
Okay.
is concerning the low molecular weight heparins. According to up to date, an example like enoxaparin, it has a half life of it has a duration of action of about 12 hours. So I was wondering if you are given a prophylactic dose, like with frequency of administration just once daily, how does it like cover for prevention of like possible DVT? Because its duration is just 12 hours.
So the fact that it has duration of 12 hours doesn't reflect the onset of, doesn't reflect the anticoagulation effect. So we are looking at the anticoagulants that have been inhibited. Once you inhibit the anticoagulant, it will stay inhibited for the rest of their half-life. So it would, just like the warfarin, once they have been inhibited, you can't activate them till their half-lives have been exhausted. So when you look at the heparins, basically their mechanism of action is they activate antithrombin 3. And antithrombin 3 is able to inactivate. So antithrombin 3 is a body's natural anticoagulant. So just like protein C and S, we have antithrombin 3 as a body's natural anticoagulant. So heparin activates antithrombin 3. And what antithrombin 3 does is it inactivates two clotting factors. It inactivates factor 10A and factor 2, which is thrombin. So inactivate factor 10A and thrombin. And when you look at factor 10A, the half-life of factor 10A is long. Remember that when we're talking about the warfarins, we mentioned the half-life for factor 10. We said it has a half-life of 36 hours. Then factor 2, which is thrombin, has a half-life of 50 hours. So all these will be inactivated throughout their half-life. So just once daily dosing is enough to do that. I don't know if you are okay.
Yeah, yes, please. Thank you.
Any other question?
Sir, can you please repeat what you just explained?
Well, that's what I'm coming to talk about. Is the mechanism
Okay.
of action. All right, so let's talk about the mechanism of action. So I said for the heparins activate antithrombin 3. And antithrombin 3 is part of the body's natural anticoagulant. So just like protein C, protein S, they have antithrombin 3 as one of the body's natural anticoagulant. So what antithrombin 3 does is it inactivates thrombin, which is factor 2. Then it also inactivates factor 10A. So factor 2A and factor 10A are inhibited by antithrombin 3. So what heparins do is they activate antithrombin 3. Once they activate antithrombin 3, antithrombin 3 is able to inactivate factor 2A and factor 10A. Once these are inactivated, it means that the onset of anticoagulation of heparins can kick in. So that's in simple terms how these agents act. But one may ask, why is it that we are saying antithrombin 3 is a body's natural anticoagulant? So what do we need heparin for? Because antithrombin 3, so what is heparin doing different? That is what we want to understand. So what happens is when heparin binds to antithrombin 3, it's able to cause a conformational change in antithrombin 3, changing it from a slow inactivator to a rapid inactivator. So in normal instances, without heparin, antithrombin 3 is able to inactivate thrombin and also factor 10A, but it does it at a slow pace. So it's a slow inactivator of factor 10A and factor 2A. So the moment you give heparin, heparin is able to cause a conformational change in antithrombin 3, converting it from a slow inactivator to a rapid inactivator. And this conformational change can cause about 2,000 to 4,000 fold increase in the activity of antithrombin 3. So if it was doing it at a pace of 10 folds, when you give heparin, heparin is able to change it from 10 folds to about 2,000 to 4,000 fold. It is able to inhibit factor 2A and 10A at a very rapid pace. So that is how heparins act. They cause a conformational change, causing antithrombin 3 to change from a slow inactivator to a rapid inactivator. Is it clear? All right. So that's the same mechanism for the low molecular weight heparins. They are all heparins. But the only difference is that the two are causing inactivation of factor 2A and 10A. But inactivation of factor 2A is done usually by the unfractionated heparin. But the factor 10A can be inactivated by both unfractionated and the low molecular weight heparin. So that's the difference.
So please,
So
one more
in
time.
terms of the
Internet
inactivation,
issue.
so in terms of the inactivation of factor 2A and 10A, we are saying that the unfractionated heparin can inhibit both factor 2A and factor 10A. But when you give low molecular weight heparin, its activity is more on the factor 10A with little activity on the factor 2A. Is it
Okay,
clear?
thank. Yes, sir.
All right. So let me explain this. Remember that when we started talking about the heparins, I made mention that the unfractionated heparins are made up of 45 saccharide units, and the low molecular weight heparins are made up of 15 saccharide units. The relevance of this is before you can inactivate thrombin, which is factor 2A, you need to form a ternary complex. There is a complex known as ternary complex. And this ternary complex is a complex of factor 2A, which is thrombin, antithrombin 3, and the heparin you are given. So this ternary complex is what is needed to inhibit factor 2A, which is thrombin. If you are not able to form the ternary complex, that means you have very little or no activity against factor 2A. To be able to form this ternary complex, that molecule should have at least 18 saccharide units within the molecule. So before you can form a ternary complex, which is needed to inhibit factor 2A or thrombin, you need at least 18 saccharide units in your molecule. So when you look at heparin, unfractionated heparin, it has 45 saccharide units. So it's able to efficiently inhibit factor 2A by forming the ternary complex with antithrombin 3 and factor 2A. When you look at the low molecular weight heparin, they have 15 saccharide units, which is not up to the 18 saccharide units. So its effect on factor 2A is very little because you need at least 18 saccharide units to be able to efficiently inhibit factor 2A. So its effect is more on factor 10A with very little effect on factor 2A. But unfractionated heparin can inhibit both factor 2A and 10A efficiently. Are you clear on that?
Hello,
All right.
sir.
So aside the
Hello, sir.
okay,
Can you please
okay.
take it again?
So I was just talking about the ternary complex of the heparin, antithrombin 3, and thrombin. Before you can form the ternary complex, the molecule or the anticoagulant should have at least 18 saccharide units. When you look at unfractionated heparin, it has 45 saccharide units. Then the low molecular weight heparins have 15 saccharide units. So to be able to inhibit factor 2A, you need to form a ternary complex with the factor 2A and antithrombin 3. And before you can form this complex, you need 18 saccharide units. So unfractionated heparin with 45 saccharide units is able to efficiently inhibit factor 2A. But we are saying low molecular weight heparins, which have 15 saccharide units, are not able to efficiently inhibit factor 2A because you need at least 18 saccharide units to be able to efficiently inhibit factor 2A. So the relevance is that unfractionated heparin is able to inhibit both factor 2A and factor 10A efficiently, whilst the low molecular weight heparin inhibits factor 2A to a lesser extent. Its activity is more on factor 10A. Is it clear?
Yes, please. Thank you.
So aside this, heparin also has effect. It's able to inhibit factor 12A, factor 11A, factor 9A, and factor 8A. So aside factor 2 and factor 10, it's also able to inhibit factor 12A, factor 11A, factor 9A, and factor 8. So let's take note of this. And looking at all the clotting factors I've mentioned, you realize that heparin will act more in the intrinsic pathway because that's where you have factor 12, factor 11, factor 9, factor 8. All these are inhibited by heparin. So its effect is more on the intrinsic pathway and
the common pathway, whilst warfarin inhibits more of the extrinsic pathway and the common pathway. All right, so let's move on. So in terms of side effects, one of the common side effects I want us to talk about is heparin-induced thrombocytopenia. Heparin-induced thrombocytopenia (HIT). So for heparin-induced thrombocytopenia, we have two subtypes. We have type 1 heparin-induced thrombocytopenia, and we have type 2 heparin-induced thrombocytopenia. So let's take note of that. Type 1 heparin-induced thrombocytopenia and type 2. For type 1 heparin-induced thrombocytopenia, this usually occurs within 2 days of putting the patient on warfarin. So if you put, heparin, if you put the patient on heparin and after 2 days, you realize that the platelets are going down, then it's likely to be heparin-induced thrombocytopenia type 1. Whereas for type 2 heparin-induced thrombocytopenia, this will usually occur 4 to 10 days after putting the patient on heparin. So within 2 days of putting the patient on heparin, if there's thrombocytopenia, it's likely to be type 1. If it's 4 to 10 days after putting the patient on heparin, then it's likely to be type 2. It's very important to know whether it's type 1 or type 2 because the management differs and the pathophysiology or what actually happens is also different. So for type 1, it's usually a physiological response to the heparin you give. So when you give heparin, it's able to cause some level of platelet activation and it can cause thrombocytopenia. Whereas for type 2, this is immune mediated. So for type 1, it's non-immune, it's physiological. Whereas type 2 is immune mediated. So what happens is that for type 2, when you put a patient on heparin within 4 to 10 days, you start seeing drop in the platelets. And this is because of an immune reaction or immune response that takes place. So what happens is when you give heparin, heparin is able to bind to a molecule called platelet factor 4. So platelet factor 4 is a protein that is released by platelets. So heparin binds to platelet factor 4. This platelet factor 4 and heparin complex is immunogenic. So what it means is that heparin and platelet factor 4 complex is able to stimulate the immune system to produce antibodies. So because of this complex, heparin and platelet factor 4 complex, there's immune activation causing the production of antibodies. And what these antibodies do is they also come to attach to this complex. So they surround and attach themselves to the complex. So what happens is now you have heparin, platelet factor 4, and antibody complex. So 3 complexes now. So heparin, platelet factor 4, and antibody. So when you have this complex is able to stimulate platelets, more platelet aggregation. And when you have more platelets being activated and migrated to the site, you can have platelets aggregating, and once you have platelets aggregating, you can have thrombosis occurring. And once you have thrombosis, which is utilizing the platelets, you can have a drop in the platelet count. So what happens is, instead of heparin-induced thrombocytopenia occurring in type 2 alone, you have what we call heparin-induced thrombocytopenia with thrombosis. So HITT. So heparin-induced thrombocytopenia with thrombosis. If you compare it to type 1, there is no thrombosis. There's a slight drop in the platelet count, and you don't have to stop the heparin you are giving. You continue giving the heparin, the platelet count will normalize on its own. So that's type 1. But for type 2, there is heparin-induced thrombocytopenia with thrombosis. So what you need to do is you have to stop the heparin you are giving and switch to another anticoagulant because there's thrombosis. This thrombosis is induced by heparin. So you have to stop the heparin and use another alternative. Is it clear? Are you okay on that?
Sir, please, I'm not
All
okay.
right. Which part are you not okay?
Sir, what you just said, just the latter part.
So I said heparin-induced thrombocytopenia type 1 is a physiological response. It's not immune mediated. It doesn't require you to stop the heparin. You continue the heparin, the platelet count will come back to normal. With heparin-induced thrombocytopenia type 2 is associated with thrombosis, is immune mediated. And for that, you have to stop the heparin and you have to switch to another anticoagulant because the patient is having thrombosis. So you can switch to another anticoagulant, but it shouldn't be any heparin-based anticoagulant. It shouldn't be warfarin. You can do these direct thrombin inhibitors like bevalirudin, agatroban, dabigatran. You can do those agents, the hiridines, bevalirudin and all that. But you shouldn't do any heparin containing, any warfarin, because they further cause thrombocytopenia. They can worsen the situation. Any other questions? All right. So what I need you to know is low molecular weight heparins have less risk of causing heparin-induced thrombocytopenia, whilst unfractionated heparin has a higher risk of causing heparin-induced thrombocytopenia. Then the other thing I also want you to know in terms of the side effects is that you can have hyperkalemia. So you can have hyperkalemia as a result of heparin therapy. And this is because heparin is able to inhibit the secretion of aldosterone. So heparins are able to cause inhibition in the secretion of aldosterone. And you know the purpose of aldosterone. supposed to cause sodium and water retention, then excretion of potassium. So if you are inhibiting the secretion of aldosterone, that means you have less aldosterone available to cause sodium and water retention and excretion of potassium. If potassium is not being excreted by aldosterone, that means you can have accumulation of potassium. So hyperkalemia can ensue from heparin therapy. So take note of that too as well. Then in terms of bleeding risk, the risk of bleeding is higher with the unfractionated heparins compared to the low molecular weight heparins. Then for pregnant women, these agents are preferred in
Hello, sir.
pregnancy. Yeah,
Please, can you take it again? What you just said, the bleeding part.
I only said the bleeding risk is higher with the unfractionated heparins compared to the low molecular weight. All right. Then I was talking about, what was I talking about?
Pregnant women.
Yeah, so for pregnant women, I said these heparins do not cross the placenta. So very little or no crosses the placenta. So they are the preferred agent if the patient is pregnant. So for example, if the patient was pregnant, if the patient was already on warfarin and the patient became pregnant, you'd have to stop the warfarin and switch the patient back to the heparins, especially in the first trimester. After the first trimester, you may switch to other agents, but first trimester, the heparins are the preferred agents in pregnancy. Then, in terms of antidote, what's the antidote for the heparin when you have overdose? What's the antidote?
Vitamin sulfate.
Protamine sulfate. That's true. Protamine sulfate. So one thing about protamine sulfate. So let me ask you this. So protamine sulfate is obtained from the fish sperm. So it's obtained from the fish sperm oil. And because of that, the patient is on, say, insulatard. Insulatard is isophane insulin NPH. The NPH stands for neutral protamine H down. So they use protamine to make insulatard or isophane insulin. So the patient has allergies to insulatard or isophane insulin. They may have cross sensitivity to protamine sulfate because they are both obtained from the fish sperm. So because of that, we may have cross reactivity. The other thing is protamine sulfate that we are saying is the antidote for heparin. This protamine sulfate has intrinsic anticoagulant effect. So protamine sulfate can cause thinning of blood as it has intrinsic anticoagulant effect. It can cause bleeding. And we are also saying if the patient is on heparin and is bleeding, we can reverse it with protamine sulfate. How is it possible? Can someone explain? So what you need to know is heparin, we said it has a higher molecular weight. Aside that, it's also charged. So um, the charge, heparin is negatively charged, whereas protamine also has a high molecular weight and is positively charged. Looking at the two, when there's heparin-induced bleeding and you give protamine, what protamine does is protamine forms a complex with heparin. And by forming a complex with heparin, the positive charge neutralizes the negative charge of heparin, and their molecular weight is able to fit in perfectly because they are both high molecular weight compounds. So protamine is made in such a way that is able to completely neutralize heparin because of the positive and negative charge and the molecular weight. So that is why we don't see the anticoagulant effects of protamine when we give it, because this intrinsic anticoagulant effect is neutralized when it forms a complex with heparin. So they both have anticoagulant effects. But when you give protamine and they form a complex, positive and negative, they form a neutral molecule. And this neutral molecule doesn't have anticoagulant effect. So both anticoagulant effects are neutralized, and their positive and negative charges are also neutralized. So that is why, even though protamine has intrinsic anticoagulant effect, we still use it as an antidote for heparin overdose. And what is the ratio when you are giving protamine for heparin overdose? How much protamine neutralizes how much heparin? Anyone?
1 milligram
All
of
right. So
protamine neutralizes 100 milligram of heparin.
okay. So 1 milligram of protamine neutralizes 100 units of the heparin. So when you take 40 milligram clexane, so that 40 milligram clexane is 4,000 units. And we are saying 1 milligram of protamine neutralizes 100 units of the clexane. So that means for 4,000 units, you need 40 milligram of the protamine sulfate. So that is how the ratio is done. But you should know that the maximum dose is 50 milligram. So even though 1 milligram neutralizes 100, when you are getting doses above 50, you still have to give a maximum of 50. So that's the maximum dose. And for the dosing, the prophylactic dosing, I've already mentioned, clexane is 40 milligram daily for prophylaxis. The heparin is 5,000 units every 8 to 12 hours. So that is for prophylaxis. So in terms of treatment, what is the treatment dose for enoxaparin if you want to treat David?
One milligram per kilogram BD.
So you do 1 milligram per kilogram BD, or
1.5 milligram per kilogram daily.
yeah. So 1 milligram per kilogram BD or 1.5 milligram per kilogram daily. Okay. What about what's the treatment dose for heparin? Anyone? All right. So for heparin, you give 80 units per kilogram IV bolus start. So you give 80 units per kilogram as a start dose. Then you continue with an infusion. So you do a continuous infusion of 18 units per kilogram per hour. So you give an initial loading dose of 80 units per kilogram IV bolus. Then you do a maintenance of 18 units per kilogram per hour. So that's the dosing for the heparins. And also take note that the heparins can also cause osteoporosis as a side effect. Yes, that the mechanism is different from the warfarin. They tend to cause decrease in bone mineralization by increasing osteoclast activity. You know, the osteoblasts are the bone forming, the osteoclasts are the bone breaking. So they increase the osteoclast activity. That causes the breakdown of bones. So long-term use of heparin would usually predispose you to osteoporosis. We've also mentioned hyperkalemia. We've mentioned the bleeding, and we've also mentioned the heparin-induced thrombocytopenia. All right. Any questions on the heparins? Any questions on the heparins? All right. So if there are no questions, I think we'll end here for today. Then our next meeting, we'll try to finish up the various anticoagulants and something small on P. P, all that we need to talk about is a subclassification. The management is the same thing. So all that we are talking about, the management will apply to P. The diagnosis will differ and the classifications of P and clinical symptoms. All right. If there are no questions, we'll end here. Have a good evening.
Bye.
Yeah, bye
Thank
bye.
you.
Bye.